Thank you, sir. Good evening, all. I'm happy to introduce all of you the speaker, today's speaker, Dr. Shabeer Ali, who is my MS batchmate. He belongs to the 41st batch of MBBS from Calicut Medical College, and we did our MS together from Calicut Medical College itself, 2004 to 2007. And he did his MCH gastroenterology from Trivandrum Medical College. And currently he is working as a hepatobiliary surgeon, transplant surgeon in Kim's Hospital, Trivandrum. He basically belongs to Perindalmanna. He is a native of Perindalmanna. And I'm very happy to introduce him to all of you. And I welcome Dr. Shabeer Ali with the permission of the President and Secretary. Thank you.
Over to Dr. Shabeer Ali. Thank you,
Okay,
Dr.
thank
Shabeer
you.
Ali.
Yeah, good evening, my respected teachers, my dear colleagues and friends. First of all, I thank the organizers of Malappuram Surgical Club for giving me this opportunity to present my experience with this condition, this acute pancreatitis, in front of my teachers and my colleagues, and maybe some of the students there in MES and other budding surgeons also. And I thank Ranjit for that, Ranjit and Sir Dr. Sajid for that introduction. Straight away, I'll go to this topic. It's a very vast topic, as you all know, and it's very difficult to cover all the aspects of pancreatitis in one talk. So what I thought is I will share what is relevant for the surgeons. Even that is going to be a very long talk. So what I will do is I will do some of the key points in the beginning and then go to one case capsule. One of the straightforward cases, how we manage this infected necrosis. And then I'll give some discussion, but at any point, if you feel it's becoming boring and getting stretched, please tell me, I'll stop. So this condition, when I was asked to talk in this Malappuram Surgical Club, actually Dr. Sajid told me to present some major cases or something like that. But I thought I'll choose this topic because it's one of my favorite topic. And another important reason is this is an important topic for the budding surgeons and trainees, because this is one condition which trains them. I believe all surgical units should take special interest in this condition, because this helps to train our trainees and budding surgeons in a comprehensive surgical care of patients, because this involves how a multidisciplinary care is required to manage a condition. And then again, how to take a decisions in surgery. Though the surgery in this condition is not a major big surgery, but it gives a lot of importance how you decide when to operate a patient, when not to operate a patient. And again, some of the how to utilize our elite specialties like interventional radiology, critical care, how to utilize our medical gastroenterology colleagues, and how to utilize our infectious disease, how to learn the principles of infectious disease, and also how to consider this another condition which carries huge financial burden to the patient. So how to plan patients' financial how to take care of the financial concerns of the patient. So this gives a comprehensive this gives an opportunity to have a comprehensive training in surgery. So that's why I choose this topic, and it's basically for the budding surgeons and surgical trainees there. So coming to the overview, severe acute pancreatitis actually carries a very high mortality. Even in the current era, it has improved because of the improvements in critical care and some of the recent changes in the surgical management. But still, it carries a mortality between 30%. And cause of death in severe acute pancreatitis is usually either organ failure in the early phase or complication related to infected necrosis. And as I have mentioned, this carries a significant morbidity and financial burden to the patient. When I remember when I was a trainee and all, I used to get this topic was actually troubling me, because when I start reading this topic, we'll see a lot of scoring systems, a lot of classifications and all those things. But later on, when we started practicing, I understood most of things are not straight away. They are important, but especially for the critical care or in the at the admission time where you need to triage patients or to prognosticate patients. But as a surgeon, I felt most of things are not so important. What I felt is more important is this Revise Atlanta gives a very good outline for surgeon to understand this condition. There are basically three categories of pancreatitis. That we have the mild acute pancreatitis, where you have a pancreatitis patient with no organ failure, no local complication apart from an interstitial edematous pancreatitis. The next category is a moderately severe pancreatitis. It is called moderately severe actually. It's a transient organ failure. That is either usually a respiratory failure which is lasting for less than 48 hours, or local complications like collections or necrosis or antecedent and events related to that. Severe pancreatitis is a persistent organ failure which is lasting for more than 48 hours. So this classification generally helps us to categorize our patients and to take decisions in pancreatitis, basically for the surgeons. And early phase of pancreatitis, this is important for us. This is basically less than 7 days, and the problems in the early phase are related to the inflammatory response syndrome and organ failure. And late phase is beyond 7 days, though organ failure can continue in some of the patients, but this is basically related to the issues are related to collections and necrosis and infection related to that. So this is again the definition of organ failure. This just to know that this organ failure in Revise Atlanta is defined by this Marshall scoring system. And then Revise Atlanta classification, again for the surgeon, some of the important things are necrotizing pancreatitis means there is presence of necrosis either in the pancreas, in the peripancreatic tissues. In most cases, you will have a combined both pancreatic and peripancreatic necrosis. Then fluid collections and necrotic collections, they are called acute necrotic or acute fluid collections when they are within 28 days of index pain. Pseudocyst or walled-off necrosis when they are more than 28 days. This is again important for decision making in for the surgeon. Then collections can be either sterile or infected. I'll come to these points later. What is more important in acute pancreatitis is basically it needs a multidisciplinary care. And most important, as I have mentioned in the first phase, it is a critical care. These patients have inflammatory response and organ failure that need a good critical care. Then radiology and intervention radiology, because most patients in the second phase, management is basically by the radiology imaging and interventional radiologist. Then medical gastroenterology, because some cases may need an endoscopic intervention. Surgeon is important because some cases may need operation or may need a percutaneous approach. And then again, infectious disease is most important because these patients have a prolonged course of infection, especially when they develop an infection in the collection. So this is important. Who should lead the team? In the first phase, all of us know there is no confusion in the early phase because it's a phase of organ failure and inflammatory response. The critical care person should lead, the critical care team should lead the overall show because it's a management of organ failure and inflammatory response. Coming to the second phase, late phase, it's basically complications of collection and necrosis. Many people are involved in the management like critical care because some of the patient can have a continuing organ failure and inflammatory response. So critical care will be involved in this phase. Surgeon will be involved because eventually some 1/3 of these patients will reach to a necrosis which requires surgery. And medical gastroenterology, because one of the recent advances is some patients can be managed by endoscopic interventions. Interventional radiology is again an essential component of management of necrosis nowadays because majority of cases of infected necrosis will require their help. And then infectious disease, as I have mentioned, this is one complex situation where you have all possibilities of infection. Even the bacterial and fungal infection itself can give you a lot of trouble. So ID physician and an antibiotic protocol, strict antibiotic protocol is required in this condition. But among this, I believe in the second phase, all the issues are related to complications of necrosis and infected necrosis. I think surgeon should lead the team. We should have a track of the overall events, and we should be aware that some of the complications like bowel perforation can happen in this condition, and then choose the best approach in a given patient of infected necrosis. Even if the other people may be intervening, that decision making now, which approach to choose, whether should we go surgically, we should go percutaneously, we should go endoscopically, that decision should be made by the surgeon. Then again, timing of intervention, that is also important. And important. Then cholecystectomy. Some of the patients with biliary pancreatitis may require a cholecystectomy. So that is again, surgeon has a role there. Then to rule out a pancreatic or peripancreatic, this is also another. I'll come to this aspect later. And more importantly, that's as a leader, they should keep a track of the events from the index pain, what all are happening keep it in a chronological order, and that will help a lot in decision making in this condition. And again, I believe more than physician, we surgeons are always concerned about the cost, especially in corporate setups and all. When we plan a surgery, we think about the cost, how to reduce the cost. So in this condition, we need a very good planning to reduce the cost from the beginning itself. So again, I believe surgeon can lead in that aspect also very well. Then role of surgeon, in coming back to the surgeon's role specific, is there any role for surgeon in the first phase? First, this is important for the trainees. Whenever there's most of the time an acute abdomen, the surgical trainee may be seeing in the emergency department. So evaluation of acute abdomen, this possibility should be considered in all acute abdomens. And nowadays, I think most emergency department protocols have amylase and lipase as a part of it, because it can mimic many other conditions also. So always do an amylase lipase in all acute abdomen conditions. And a cross-sectional imaging is, please do a cross-sectional imaging. This is again, most of the departments are doing it now, at least a plain CT scan when there is a doubt about the diagnosis, which will help in diagnosing, ruling out a perforation and also making a diagnosis of pancreatitis. In some cases, if you have an obvious amylase lipase, which is very high and a clinically typical of pancreatitis, you can make a diagnosis at that time and delay that imaging for 4 to 5 days for the necrosis to evolve. But when in doubt, always do at least a plain CT scan at that stage. And this is important because a wrong diagnosis and a surgery on a patient with acute pancreatitis can cost a life, because these are the patients with severe inflammatory response. And if you operate them, it will add on to the inflammatory response and it can lead on to very major complications. Again, another important situation where surgeon may be called in by the critical care physician. We often get a call on the 4th day, 3rd day, 4th day after an acute pancreatitis. The critical care physician will call and tell this patient's intra-abdominal abdomen is very tense. He is not tolerating feeds, and they may measure the bladder pressure and say his abdominal pressure, his intra-abdominal pressure is very high. Please do something. Please do a laparoscopy. Is it recommended? Actually, this surgical laparoscopy has very limited role. The management of a compartment syndrome in acute pancreatitis is basically most important is prevention. That is one important reason for developing. Previously, people used to give a lot of fluids in the acute phase. Now that concept has changed. It is a goal-directed. Either you monitor the hematocrit or it's a goal-directed therapy. Other parameters. There are many ways. That itself is a big topic. So goal-directed fluid management, optimum fluid management. If you give a lot of fluids in the first after the first 24 hours, it will sequestrate in the third space, and you will get a lot of bowel edema. And this one main reason for compartment syndrome. So fluid therapy, proper fluid therapy will help to prevent this condition. And if there is a fluid overload, as already happened, you go for a diuretics or CRRT to reduce the fluid overload stage. Then decompression tubes may help in this condition, like nasogastric drainage, prokinetics, and rectal tubes to evacuate the colonic gas. And some cases, even an endoscopic decompression of the colon may help. And then, even with all these conservative measures, if the abdominal compartment pressure is not coming down, ventilate the patient, sedate, and give a complete neuromuscular blockage, completely paralyzed. This is otherwise known as pharmacological laparoscopy. A surgical laparoscopy has a very limited role in acute pancreatitis, because these patients, this type of patient who has a tense abdomen and compartment syndrome, they are the sickest acute pancreatitis patients. They are already having multiple organ failure. So an added surgical insult usually has a very negative effect on these patients. So it's not generally recommended. Then again, other important role in surgeon, drainage of collections. This is usually we don't do any drainage of collection in the acute phase, but there are some caveats in this situation. I will discuss that later when discussing the infected necrosis. Rare complications like bowel ischemia and perforation That also in acute, if a patient develops a bowel ischemia and perforation due to some vascular thrombosis in the acute phase, this is again a very bad patient. They are unlikely to survive. Another important area before going into the proper infected necrosis, another important role for surgeon is in the biliary pancreatitis. Though ERCP is done by our medical colleagues nowadays in most places, we should know when to ask for an ERCP in an acute biliary pancreatitis, because it's not generally recommended for all cases of biliary pancreatitis. It is indicated only if there is an imaging detectable CVD stone, or there is evidence of a biliary obstruction or imaging or on biochemistry. Without a biliary obstruction, just for a biliary pancreatitis, because most cases it will be a passed off sludge, in that case don't attempt an ERCP. Though there are some literature on saying that an early ERCP in biliary pancreatitis may improve the cause, but our personal belief is if you do an ERCP on a severe acute pancreatitis, especially with a necrosis, we have noticed an higher incidence of infections in these patients. Then again, lab cholecystectomy. This also for PGs, it is very important when to do lab cholecystectomy in this patient. Cholecystectomy in acute pancreatitis is basically prophylactic. The event has already occurred. In the existing event of pancreatitis, cholecystectomy doesn't have any impact. So it is indicated to prevent further episodes of pancreatitis. In a mild pancreatitis, no local complication, no organ failure, it should be done at the earliest and preferably in the index admission itself. For a patient with already developed organ failure or local complication, you wait for the organ failure to resolve, wait for the local complication, either the local complication to evolve, which may require a surgical intervention, and do it along with that, or wait for the local complication to resolve and then do it. Usually it is after 2 to 3 months. So again, this is another important aspect which surgeons should know. Most cases of pancreatic cancer can have a mild acute pancreatitis, and it has no relevance, clinical relevance, because the pancreatic cancer, this may indeed help us in doing a Whipple's operation, because the gland may become firm by having a recurrent acute pancreatitis. But what I am talking about is a severe acute pancreatitis as a manifestation of pancreatic cancer, which can also happen rarely. We had a few cases in the recent past. This importance of this is it is a very difficult diagnosis, because in the phase of acute pancreatitis, and if there is some pancreatic necrosis and collection, it is very difficult to make out a mass lesion in the pancreas on imaging. So consider in any high risk patient, like an elderly patient without any other risk factors like gallstone or no alcohol, an elderly patient developing a severe acute pancreatitis, always think about this possibility. Nowadays, we do a delayed imaging. After the acute event is resolved and after the local complication are resolved, we do an imaging just for looking at a pancreatic cancer in such a high index patient. Then there are some concerns also in severe acute pancreatitis, because these patients have an ongoing inflammation and surgery can be very difficult, and we always have to counsel the patients regarding a backing up of maybe an abandoning of surgery on table. This was one of our recent patient who had a severe acute pancreatitis, and with the second episode of pancreatitis from an outside center, they have diagnosed a periambulary cancer. Endoscopic biopsy was positive. Then it was attempted for a Whipple's resection. First was attempted robotic and then attempted open. 2 attempts in a two-week interval, and then they have abandoned the procedure and then put a metal stent, self-expanding metal stent for biliary obstruction, and sent for a palliative chemotherapy. This patient actually came to us. By that time, his pancreatitis was resolving. This is one condition where you can use a neoadjuvant therapy. Now, pancreatic and periambulary cancers, neoadjuvant is coming up. So this is one situation where you can neoadjuvant chemotherapy and buy some 2 to 3 months and then attempt the surgery, and we may be able. This patient we could operate with a safe outcome, a good outcome after some 3 to 4 months of neoadjuvant therapy. So another important aspect is nutrition. In acute pancreatitis and all complications of pancreatitis, always the most recommended is enteral nutrition, and I think now in most units enteral nutrition is preferred, and oral, if they are tolerating, oral feeds are given. Otherwise nasogastric, and especially in the sick patients on multiple organ supports, or nasojejunal if nasogastric is not tolerated. Parenteral nutrition is very rarely required in acute pancreatitis, except in the very acute phase where they are on very high inotropic support or multiple organ failure, that situation, when the bowel is not tolerating, we may start, otherwise generally not. And another important thing is when you have when they have a long course, like by the time they reach to the second phase and infected necrosis, if the nutrition is not taken care properly, they will be very catabolic, and you can have a very negative outcome in the management of infected necrosis also. So nutrition and maintaining a daily calorie protein chart is very important in acute pancreatitis, especially beginning from the early phase. Now going into our most important aspect for the surgeon, that is the pancreatic necrosis and infected pancreatic necrosis. Severe acute pancreatitis happens in around 10 to 15% of patients. Mortality of severe acute pancreatitis is around 10 to nearly around 30%. Now it has come down to around 15 to 20%, and 20 to 30% of the necrotizing pancreatitis infection will happen as a complication. And 40% of the severe acute pancreatitis, the mortality is related to infected necrosis. I'm audible? Hello?
Yes, sir, audible, sir.
Yes, Shabeer, you are audible.
Okay. Yeah, so infected pancreatic necrosis, another important aspect is this prolonged morbidity and financial concerns related to it. So again, revise Atlanta, acute necrotic collection is within 4 weeks, and more than 4 weeks, you call it an acute walled off necrosis or WON. And then pancreatic necrosis happens in 5%, and peripancreatic in 20%, and most cases will have a combined pancreatic and peripancreatic necrosis. So to discuss the infected necrosis, how we manage in our unit, I have taken a case which was actually a straightforward case. Most of the situation will be having some deviations from this straightforward course. But this is to, especially for the PGs, to understand how is this step-up approach is utilized in infected necrosis.
Shabeer, your screen is not seen. Please share your screen.
Hello?
Please share your screen.
Okay. Go back. Share. Visible now?
Yes, sir. Yes, sir.
No.
It's coming, sir.
Coming, okay.
Yes, sir.
Yeah, now you can see.
So okay now?
Right.
Yes, sir.
Okay.
Yes, sir.
You can see now.
So this was a 65-year-old male with no comorbidities, presented with abdominal pain, fever with chills, and presenting on day 1 of the index pain. He presented on day 1 of index pain. He had a very high bilirubin of around 6 and a transamin significantly elevated liver enzymes, and amylase was 3,800 and lipase was 5,500. This patient underwent an MRI. Usually our standard imaging, if there is a diagnostic confusion, we do a plain CT abdomen when there is a suspicion of perforation or any other things. Otherwise, we usually delay the imaging for a 4 to 5 days for the local complications to evolve in severe acute pancreatitis. But most patients will have a plain CT, plain imaging at least at the admission itself. This patient straight away underwent an MRI because he had a cholangitis part was more predominant at that stage, and we wanted to rule out a CBD stone. MRCP has shown a CBD stone with biliary obstruction. So on day 2 itself, he underwent an ERCP and stone extraction. And in the early course, he was admitted to ICU with transient respiratory failure. There was a clinical improvement in 2-3 days and he was shifted to room. He was doing well. Then on days 7 to 10, he started developing recurrent pain in the abdomen, fever spikes and becoming unwell, and abdominal distension also. So there was a fall in saturation also. That is a new onset organ failure again. LFT has normalized by that time. Total counts and CRP was rising. So we did a CT abdomen at that time, which has shown an extensive severe pancreatic and peripancreatic inflammation, and a contrast imaging is showing a necrosis, significant necrosis involving the pancreas, and there is a biliary stent in situ. So fever on day 7 from index pain. What are all the possibilities? Can we have an infected necrosis at this stage? Usually infected necrosis occurs after 14 days of time. Very unusual to have infected necrosis before 7 days. So always look for other causes like line sepsis, cholangitis, UTI, or even in COVID in the present era. So look for other causes for fever. And another important thing is inflammatory fever. In the first and second week of pancreatitis, you can get inflammatory fever. How do you differentiate this inflammatory fever and what is the relevance? Because this is basically because of the ongoing local inflammation. Patient may get an intermittent fever, but those patients will be usually well. They might have got shifted out from the ICU. They will be walking around with an on and off fever. Inflammatory markers will be usually either stable or improving. You will be eating well. So this is the common presentation of inflammatory fever. It is important to differentiate an inflammatory fever at this stage, because if you start antibiotics straight away at that stage, you are going to increase the cost of treatment, because eventually they may later on require antibiotics for the infected necrosis. And another thing is using antibiotics when there is no infection, it can eventually cause an antibiotic resistance also. And again, cost is also an important aspect at this stage, as I have mentioned. So it is important to differentiate inflammatory fever. So any patient developing a fever, look for other causes. Think about inflammatory fever, especially if the patient is well and only fever is there. Then again, infected necrosis. How do you diagnose infected necrosis? This patient but had a deteriorating cause. He is developing a new onset, again getting some tachypnea and respiratory failure. So how do you diagnose infected necrosis in pancreatitis? There is a definitive diagnosis and there is a empirical diagnosis. Definitive diagnosis, when you have a culture positive, either during your surgery or a percutaneous. Some patients we may do a percutaneous aspiration just to get a sample and do a culture. If that has come as positive, or later on you have a pancreatic necrosis you took out because of symptomatic necrosis and it has given a positive culture, or presence of significant extraluminal air on CT scan, it is a definitive diagnosis of infection and you have to treat it as infective necrosis. But what is suspected, what is more common scenario is actually an empirical diagnosis of infected necrosis. This is a situation where you have a patient on multiple organ support. He was just improving and then again going down. He is developing a new onset organ failure, or the existing organ failure is persisting even after 7 to 10 days of good supportive care, or worsening of the existing organ failure. This is a situation where you start antibiotic thinking that the necrosis is getting infected. This is called an empirical diagnosis of infection. So we usually follow a step-up approach. In step-up approach, the first step is usually you start on antibiotics. It is not recommended to start draining the collections at a very early period like second week. If you have an evidence of infection, start antibiotic. Empirical antibiotics, generally there are many literature available, but we usually use imipenem as our first choice, because most of our antibiogram has shown sensitivity most to this antibiotic. And the common organism we have identified in our series was actually E. coli when you haven't touched the necrosis, especially when from the blood culture or from the percutaneous needle aspiration, the commonest organism was E. coli, and that will be usually sensitive. But in a patient with an infected necrosis where you have started intervening, you have put drains, the commonest organism was multi-drug resistant Klebsiella. And in those situations, we'll be usually escalating to polymyxin, fosfomycin, or sometimes even tigecycline is a very good antibiotic in this situation. So first antibiotic, always we start on imipenem and then managed in ICU. He initially again showed some improvement for 3-4 days. Then again persistent fever and unwellness in another 1 week. After 7 to 10 days, first 7 days he showed improvement with antibiotics, again becoming unwell. CRP is after coming down to some near normal value, again started going up. And at that time, the blood culture has shown a grown Klebsiella. So this is a clear evidence that he is not responding to the first step, the antibiotic. We go for a drainage at this stage. And we did a repeat CT, which has shown that we have seen a previous necrotic, evolving necrotic collection. Then now there is a tail of pancreas, peripancreatic necrosis, and some air pockets have already started appearing. So this is a clear-cut diagnosis now, infected pancreatic necrosis. We have to intervene now. So this was week 4. We started with our next step is usually a percutaneous drainage, and it's a radiologist who puts the drain, and he always, when you put the drain, majority of patients may settle with drain alone, but still he will plan an intervention also in the first drain itself. They usually put with a 14 or 16 French pigtail drain, and in a 3 to 7 days period, we serially upsize it to a 24, 28 or a 32 size surgical drain. And we may have to put additional drains when there are evolving collections in the other areas, which also happen very commonly in pancreatitis. And then we start on regular flushing once a cavity has formed, once that imaging is showing a good wall and the track is formed, we start a regular flushing either through the same drain, or you can do a counter flushing through when you have multiple drains into the same cavity. And with flushing, we have seen some 30-40% of patients settle with PCD insertion and flushing alone. And when you put the drain again, as I have mentioned, the radiologist will try to put it along the longitudinal axis of the collection, because what we are planning later is a percutaneous necrosectomy by a rigid scope. We haven't tried with a flexible, so we may need a longitudinal. If you have a longitudinal access to the collection, we will be able to clear it completely. Otherwise, if you come from one side, it will be difficult to access some of the corners of the collection. So again, that is also important. The radiologist also should have an idea about the future surgical procedures. Then we do this flushing is also very important. We do some 2 to 3 liters of this patient has 2 drains. So once if you flush through one drain, it can come out. It's a counter irrigation also you can do when you have multiple drains. And this flushing is very important because we have noticed that the outcome, and in the many literature also it is seen that outcome of this percutaneous drainage is directly related to how religiously you do the flushing. We have noticed that when we were having not much in the beginning of our unit, when we were not having much GI cases, we were very interested in managing these cases. We used to do morning and evening some 3 to 4 liter flushing. Patient used to get good outcome with flushing alone. But when we become busy, when the flushing become less intensive, we have seen more patients required further interventions like necrosectomy and all. So it is important to do a very religious flushing, give some 2 to 3 liters. If you do 2 times a day, then we teach the patient. When the patient improves clinically, we teach the bystanders how to do it very carefully and in a sterile manner. We will send them home with this flushing. And then this patient was sent home, and then he comes back on 6th week with again fever, rising counts and CRP. LFTs are normal. We did a repeat CT. Now we are seeing some persistent solid area still around the drain. And there was one new collection appearing actually along the head of pancreas. There was one collection anterior to head of pancreas also. And there was a subhepatic collection. So we put one drain to the anterior collection and then planned for a necrosectomy for the lateral collection. This is our technique is usually a drain tract necrosectomy in majority of patients whenever possible. This is the drain tract necrosectomy we do with a percutaneous nephrostomy set. You have a rigid nephroscope you can use along with that amplat sheet, and you can use a stone catching forceps also to take out the necrosis. And the drape set we use is again that we borrowed it from this urology people. That is the TURP drape we use. So we have a video of drain tract necrosis. It is a very simple procedure. Once the track is well formed, you just go through the track with a nephroscope, irrigate well with liters of saline, and first 10 to 15 minutes, you may not be able to see anything because of the cloudiness. You irrigate well. If you have done a good preoperative irrigation, usually you will have a clear vision. Otherwise, irrigate for some time, then the vision will clear. And the
Hello.
Yes. Hello, hello. Now we can hear, but video is not seen. Hello, Dr. Asif, can you hear me? Hello.
Sir, Shabeer sir just got exited, sir. So I asked him to rejoin. Just a minute, sir.
Hello.
Hello, sir.
What is the issue? Is
Sir, Shabeer
lost
sir
the line or?
exited from this, sir. Network issue, sir. Shabeer sir just got exited. I asked him to rejoin, sir.
Yes, yes. Please ask him.
The precaution we have to take is we have to be very patient. It will take time. You will not be able to take out all necrosis in one go. You will have to spend some time with it. Take out only the separated necrosis. Don't touch the cavity wall. If it starts bleeding, no, even if it is a minor bleeding, the whole vision will go. So you have to do it very carefully when entering through the track and all without injuring the side walls. And then this is again a step-up procedure. You can do it, and then after 3-4 days, you can again do it. So always try to control sepsis, irrigate well, take out all the pus which is collected in the pockets, which may not be draining through our drain, and then get to have maximum sepsis control. That is the aim. It is not a one-time procedure and to take out completely, clear the cavity and all. If you take out maximum possible, the patient will usually settle, and then the rest can be managed by continuing flushing or a later stage necrosectomy. Okay. So go back. So, okay, this is again the necrosis. Most of the necrosis usually will be flushed with the high flow, with the saline flow, but sometimes you may get big chunks of necrosis also. So then once you have done the necrosis, most of the patient settled with this necrosectomy, and then they will continue with flushing. They will have the drain for some more weeks, and then once even after the necrosectomy, usually they will have some purulence in the drain, and after some time it usually clears and the patient develops a clear pancreatic fistula. Once the pancreatic juice has cleared and the output is less than 50 ml, we usually remove the drain. Some patients after removal, most of the patient usually resolve by itself or may develop a small pseudocyst and spontaneously resolve it. But some of them you may get a symptomatic pseudocyst over time, maybe after 6 months or 1 year. We had a small number of patients who required an endoscopic or a surgical cystoenterostomy later on. Some patients with a persistent high output pancreatic fistula can be easily managed by an endoscopic stenting, or very rare patient you can do a tractoenterostomy or a distal pancreatectomy. Then this is another important aspect for in infected necrosis for the surgeons, that is a bowel communication. Majority of the necrotic collections, when we have not done any intervention, they resolve by some form of bowel communication, and they resolve by rupturing into some adjacent viscera. But most of the time it will be unrecognized and it doesn't have any clinical relevance. But what I'm talking about is an infected necrosis, and along with that you have a bowel communication. Commonest ones we have seen is a gastric fistula. Gastric fistulas are usually iatrogenic. It is like a large retrogastric collection. Somebody might have attempted an open or a laparoscopic cystogastrostomy, and the patient will transiently settle, and since they have a residual necrosis in it, they will come back again. Then we will be forced to do an percutaneous approach. Then it develops like a gastro-pancreatico-cutaneous fistula. And most of the time, this what we have noticed is when the sepsis in the cavity is controlled, these fistulas heal by itself. We rarely had any problem with this type of gastric fistulas. Then duodenal fistulas, again, especially at the early phase of the necrotic collection, we have seen a very bad outcome. And one patient had a very severe organ failure. We had to go for an open necrosectomy. And in that patient, we found out an duodenal communication. And he eventually developed a bowel leak and then sepsis, and he died. We lost one patient with a duodenal fistula. Jejunal communication, again, we have seen in some patients, especially the DJ flexure, which is very close to the tail of pancreas collections. You can have a communication there, but most of them are resolved by itself. Then another important is a colonic communication. Again, some of the collections can resolve by a colonic communication, but if you have a patient with a suspected colonic communication and a worsening clinical course, he may be salvaged by doing a diverting colostomy, proximal diversion colostomy. This is important to recognize because we are deteriorating patient. One reason can be a colonic communication, and which is leading on to a persistent infection, especially when you see even after drainage, if patient is not settling, extensive air in the collection or a fungemia. We have noticed that a high chance of fungemia is in patients with a colonic communication. Then transabdominal drainage, one important in the previous era of transabdominal drainage, one important point against the transabdominal drainage is this high morbidity and mortality associated with bowel communication. If you have a bowel communication and you have approached the collection transperitoneally, that will eventually lead on to an intracutaneous fistula. This again, we had this is one patient who had an extensive air in the collections, non-illocalized collections, and a colonic fistula with a fungemia. This patient was on multi-organ support and we could not salvage him. So going on, shall I stop here or should I discuss some relevant points? Asif?
Yes, sir. Please carry on, sir. I think there is everyone.
Okay. So one important point is related to the timing of intervention. I have told always we delay the intervention as much as possible with antibiotics and other supportive care. Why this delay for more than 4 weeks? It is generally applicable, but there are some patients whom we may not be able to delay. These are two types of one. Sometimes we had a recent patient who came on 4th day of pain, but he had a well localized collection with air in it. This is a situation where you have missed the index pain, especially in alcoholic pancreatitis. Sometimes they might have got a pain 1 month back. They might have gone to some local hospital. They may not give that history, or they might have had an unrecognized pancreatitis before. So index pain may not always work. And another thing is, so if you have a well-localized collection patient in organ failure or a new onset worsening, you can drain irrespective of the duration. And another thing is, another situation where you have to drain even before 4 weeks is you have a patient who is continuing on organ support. You have first phase, first week organ failure, not improving, continuing on organ support, evolving collections, air appearing in collection. We have drained many such patients even before 4 weeks. Why is this 4 weeks rule? It's basically in the early phase before this 2 weeks, usually it's an inflammatory response. all organ failure, everything is due to inflammatory, and your collection drainage is not going to help. And infected necrosis is rare before 14 days, usually first week or second week. And sterile collection or asymptomatic collection doesn't require drainage. And this gives another important for all our approaches. Once that necrosis is well localized, walled off, then only all these approaches, whether it is open, percutaneous, all these are applicable. So that it is another indication, is another reason why we are waiting is because we wanted it to mature and form a well localized walled off necrosis. Indications for emergency intervention before 4 weeks. This we have already mentioned: perforation, gangrene, or secondarily infected collections and all. What are the indications for? Not all patients with pancreatic necrosis, even if large necrotic collection, doesn't require intervention. As we have mentioned, infection is one commonest indication. Then persistent organ failure, mass effect and symptomatic collections. Again, if it is persisting and persistently symptomatic, we need to drain. And then disconnected duct syndrome. We have pancreatic duct disruption and antecedent complication. Definitely, we will have to intervene, but in a different way. Then, what are the common approaches? You have two major, for the trainees purpose, there are two major approaches. 10-15 years back, the commonest approach was a single stage or multi-stage open necrosectomy. It was straight away a transabdominal approach. You open the abdomen, you go transmesocolic, transgastric, or transperitoneally. You go and open up the collection. You try to remove completely. Sometimes you may give packing or laparostomy and come out. You do a planned reoperation. So that was a very morbid procedure that time. It can be either a single setting or a staged approach. Minimally invasive approaches have come up in the last 10-15 years. One commonest approach which I have shown is the percutaneous approach. That is basically radiological and then eventually going into a percutaneous drain track approach. Then there are other approaches like a open extraperitoneal, not a transperitoneal, extraperitoneal small incision or a video assisted. I will come to that later. Then another is an endoscopic transluminal approach to the necrotic collections. This was a landmark publication which has changed the practice of actually management of infected necrosis. There's a PANDA trial which came up in NEJM in 2010. It was a multi-center randomized trial comparing a minimally invasive step-up that includes endoscopic and percutaneous approaches versus a maximal open necrosectomy. Minimally invasive can be endoscopic, PCD, or what, and they have studied the mortality and complications in both groups and long-term complications also in both groups. Though the mortality was not significantly different, there were major complications and mortality together was significantly lower in the minimally invasive step-up approach rather than going one-stage open approach. And long-term complications like diabetes and exocrine insufficiency was higher in the open approach. And hernias were definitely higher in the open approach. So after this publication, only most units internationally has changed from their open approach to a step-up approach. Initial phase, it was actually this percutaneous approach, and of late, in some ideal cases, this endoscopic approach also has come up. Minimally invasive percutaneous, I have mentioned, PCD, upsizing, irrigation, then video-assisted necrosectomy is either drain track or small incision extraperitoneal. Like the way you drain an extraperitoneal appendicular abscess, you can go extraperitoneally and drain. Endoscopic approaches is basically EUS guided drainage of infected collections or infected necrosis by putting a lumen opposing stent and then go by single stage or multi-stage endoscopic removal of the necrosis. Then laparoscopic, rare cases where you have a very accessible location, you can do a laparoscopic approach also. This is the percutaneous approach which I have mentioned. This is suitable for step-up approach because you can put one drain, then another drain if patient is not improving, then you can upsize the drains. This is ideal for step-up approach. And PANTHER trial has showed a 35% of patients in step-up settle with PCD alone, and many other literature have come up after that. In our series also, nearly 50% of patients settle with a drainage alone. It is suitable for patients who are already on multi-organ failure and organ support, and then more suitable for early intervention if required. As I have mentioned, non-improving patients on multi-organ support, you want to put a drain. Surgery is going to be a very high risk on them. You can put a drain. and best for multiple wound and unfavorable location wounds which are not accessible for a transabdominal surgery. Mostly